Welcome to all of you. Thank you for attending this meeting and from very far away countries. Today, we are very proud to welcome Itai Gueta. And I would like to tell you a few words about the series that we have started in September, which is Tell Us a Safety Case Story. And this was the idea behind this series. First, we have started to do it twice a month, once in English and once in Hebrew. And the idea was to present cases. And but it's not only to present a case, an adverse reaction. The idea was really to have a highlight of what are the actions that can help us to avoid this to occur another time. So it's really very oriented to risk management and risk minimization actions. So it's a free event and it's online. It's about 30 minutes. And the idea is really to be proactive. So if you have an adverse, a kind of adverse reaction that really can help other people to learn about it and how to avoid it, please, you are invited to propose it. Right now, Itai will certainly close this for the year because we will switch to the COVID vaccine vigilance around the world. So Dr. Itai Gueta is a physician and a senior researcher. He's working in the Institute of Clinical Pharmacology and Toxicology in the Sheba Medical Center. And we can say that Sheba Medical Center has been ranked among the 10 best hospitals in the world by Newsweek for the second year in a row. So we are very proud to welcome Itai. And Itai, it's the screen is yours.
Thank you very much for inviting me. Can you see my screen?
Yes.
Yes.
Yeah, thanks. Okay, so I would like to present you a case. My name is Itai Gueta. I'm a senior physician at the Institute of Clinical Pharmacology and Toxicology, and as well as senior physician in the Internal Medicine Department A here at Sheba Medical Center. And this is basically a case that we had almost a year ago in our department, in the Internal Medicine Department. And we called the case Sleeping Beauty. And the main question was whether she can be awakened. So as any good Walt Disney story, we begin with the 83 years old female who is said to be competent and independent in her activities of daily living. She lives in a senior facility, and basically she comes to the hospital because of general deterioration in the last several weeks. There is a progressive shortness of breath and a worsening leg edema in the past 6 months. And additionally, her family reports that in the last 2 weeks, she had several falls. Those falls are said to be mainly technical, which means no syncope, no loss of consciousness, or no post-ictal period. But again, this is a new thing that they see. She arrives to the internal medicine department, and when the attending physician examines her past medical history, it is relevant for epilepsy. She has hyperlipidemia. She has morbid obesity. Both of her leg has lymphedema, which is said to be chronic. She has in the background as well osteoarthritis, gout, and osteoporosis. And when the chronic medications are examined, so it is evident that she is treated with phenobarbital and valproic acid for her epilepsy for many years already with no change in the dosage. She as well takes pregabalin, probably for a neuropathic pain, although that diagnosis was not present in her record. She is treated with simvastatin for dyslipidemia, sulfenazine for urinary bladder for the incontinence, And for the osteoporosis, she's treated once monthly with the oral risenbronate. And on physical examination, as we do in the internal medicine department, the patient looks quite somnolent. She has a high fever of 38.7 degrees Celsius. She's tachycardic, and on auscultation, it is obvious that this tachycardia is with irregular pulse. She has desaturation of 85% in room air, but it does not seem that she has any nuchal rigidity. On auscultation, there are some rails on the right lung, and as said before, both of her legs are quite edematous. She has bilateral lymphedema with probably new focal erythema and blisters. The next step is, of course, the lab results, and we can see that she has leukocytosis and left deviation. She has mild acute renal failure, most probably due to pre-renal azotemia. Her liver function tests are in the normal range. She has elevated CPK, but the upper limit of the CPK is about 200, it's 190 international units per liter. And she has an elevated CRP. So overall, we can say that she has elevated inflammatory markers. And as you can see, her blood gases were demonstrated respiratory alkalosis, severe PCO2 retention of 126 with respiratory acidosis, as said, with a pH 7.1, which is only partially compensated. Her urinary analysis also demonstrated to be pathologic. She had the leukocytosis, she had the leukocytes, nitrates, erythrocytes, proteins, and ketones in the urinary test. And the ECG demonstrated atrial fibrillation, quite a rapid one, 140 beats per minute. Its duration was unknown. She did not have any diagnosis of atrial fibrillation previously. And on chest X-ray, we could see bilateral opacities. The heart was enlarged, and our rentgenologist said that he cannot rule out pneumonia. And as a typical, let's say, elderly patient in the internal medicine department, she receives a diagnosis of a urinary tract infection, and we sometimes say versus pneumonia because we cannot rule out for sure a respiratory infection. She has as well this atrial fibrillation of unknown duration, and the somnolence, which was very prominent, was actually said to be secondary to the PCO2 retention. I would like to remind you it was 124, and probably there is some element of this acute infection in the elderly, both eventually result in that somnolence. And the patient is treated accordingly. For the infection, she receives augmentin. She is connected to BPAP in order to reduce the PCO2. We begin apixaban and bisoprolol for the rapid atrial fibrillation. And we, of course, doing therapeutic drug monitoring for both the valproic acid and the phenobarbital. Both actually were demonstrated to be in the lower therapeutic range. And after a day or two of treatment, we can see that, not surprisingly, the antibiotic treatment and the respiratory support actually work. The inflammatory markers improve, the PCO2 goes down, it decreases, and we all expect that our beauty will wake up, but on reevaluation, the physicians at the department observe that actually the patient is still somnolent. And as good physicians in a leading hospital in Israel, they go back to do reevaluation and they open the differential diagnosis of somnolence. And when we talk about the differential diagnosis of somnolence, we can divide it into three main big categories. If we make it simple, we can talk about neurological disorders, we can talk about extracranial disorders, and we can talk about psychiatric conditions. And when we talk about neurological conditions, so we say that focal CNS lesions such as stroke can obviously explain somnolence. And I would like to remind you that the patient had atrial fibrillation, which was not diagnosed, and she was not anticoagulated. So that obviously is somewhere in the higher rank of the differential diagnosis. It is possible that she has poorly controlled epilepsy, although the epilepsy is for several years there. She is not really in any follow-up. And I wish to remind you that she had elevated CPK, which also can support a seizure, and maybe this somnolence is actually a post-ictal state. It can be that she has actually encephalitis with this elevated CRP, although it went down. And of course, we have other neurological disorders such as neurodegenerative diseases, neuromuscular disorders, or migraine that are much lower in the probability here in that specific case. And when we talk about extracranial etiologies for the differential diagnosis of somnolence, we can talk about cardiovascular etiologies such as CHF, congestive heart failure, which many times can come with sleep apnea or any other respiratory origin such as COPD or obstructive sleep apnea. In that case, again, the PCO2 was actually going down and the patient was still somnolent. So it is possible, but it is not really high in the probabilities. It is possible for metabolic disorders, but again, here the TSH was in normal range. Hepatic encephalopathy, it's something that we always need to think about, but I wish to remind you that the liver function tests were actually in the normal range. There was no history for any cirrhosis or for any other hepatic disease. In the differential diagnosis, we still have an option of systemic inflammation or sepsis, but the patient did not look septic, and she was treated appropriately, and the inflammatory markers were actually going down. And we have hematologic disorders such as hemochromatosis, which is really irrelevant for that case. And of course, as a clinical pharmacologist, we always need to think about medications, and I will elaborate about that shortly. And we have another option for psychiatric conditions such as depression, anxiety, substance abuse. But again, that did not seem like the case in our specific patient. And the physicians decide to put some more effort in searching for those neurological and extracranial etiologies, and they send the patient for further evaluation as expected from internal medicine physicians, and they show that on EEG there is diffuse cortical dysfunction, but actually there is no evidence for any epileptiform discharge. The head CT turns out to be actually quite okay. There are no focal lesions, no findings supporting any intracranial etiologies, and the echocardiography actually shows a bit hyperdynamic ejection fraction with moderate pulmonary hypertension. Again, those findings do not explain the somnolence, and the physicians understand that for the moment they do not have any explanation for that clinical picture, and they go back to open the differential diagnosis, and they are left with those options. And here, usually, this is a crossroad for a typical patient in the internal medicine department, because the treating physicians can choose to take the road of further diagnostic tests, whether those more imaging or maybe some invasive examinations, or they can just hold for a second and try to review the patient medications. Because as we know, medications are responsible for many of the situations or many of the clinical pictures that we see, especially at the hospitalized patient. And when they go to review the medications to check whether one of those medications can cause a somnolence, they see that several of those can actually do that. Obviously, simvastatin, as you all know it, is not associated or does not cause somnolence, but pregabalin, which is indicated for neuropathic pain, can cause actually somnolence in up to 30% of the patients. That was judged to be quite irrelevant in our specific case because the patient took it for many years with no change in the dosage, and her pre-renal azotemia that was demonstrated initially was judged to be quite minor, so the clearance would not be really affected, but obviously it should be kept in mind, but that was lower in the probabilities. Solifenacin, muscarinic 3 receptor blocker, which is given for overactive bladder, obviously can cause as well somnolence, but again, I should stress that muscarinic 3 receptor is less abundant in the CNS. It is quite specific for the urinary bladder, and hence in therapeutic doses, it should not cause real somnolence. And of course, we have phenobarbital and valproic acid, two agents for the epilepsy that are obviously associated with somnolence. But again, here I wish to remind you that both agents were actually in the lower range of the therapeutic range, lower concentration of the therapeutic range. And the physician could easily, in that point, say, okay, so this is not a medication, but they decide anyhow to consult with a clinical pharmacologist at the Shiva Medical Hospital, at the Shiva Medical Center, and the clinical pharmacologist asked them to pay a bit more attention for valproic acid, because valproic acid can cause somnolence in a dose-dependent manner, but actually there is another mechanism which is not directly related to valproic acid itself. And to understand that, I wish to take you back for a first or second year in medical studies for the biochemistry studies, and talk a bit about valproic acid metabolism and beta oxidation. Because valproic acid is basically a short to medium chain fatty acid, which is mainly metabolized through glucuronidation in the liver. About 80% is metabolized through glucuronidation, 3% is excreted unchanged by the kidney, and about 17% is metabolized in a process called beta oxidation. Most of it beta oxidation, part of it is omega oxidation, but in a normal situation, most of those oxidation is beta. And the beta oxidation, I wish to take you to the right figure. The beta oxidation is a process that fatty acids are metabolized, and because valproic acid is a fatty acid chain, it is also metabolized in beta oxidation. And for beta oxidation to happen, the valproic acid needs to connect to carnitine and result in a valproyl carnitine metabolite, and then this carnitine goes into the mitochondria for the beta oxidation process through a channel or a shuttle called carnitine translocase or carnitine shuttle. And basically, what happens is that in the metabolites of this beta oxidation process results eventually in a deficiency of carnitine. They actually deplete the carnitine stores because the beta oxidation process here depletes itself the carnitine. The metabolites actually inhibit the carnitine translocase, and in addition, and maybe most importantly, the metabolites inhibit the endogenous synthesis of carnitine. So basically, overall, the cell has carnitine deficiency, and when there is the situation of carnitine deficiency, most of the metabolism of valproic acid, instead of being mainly beta oxidation, goes to the other channel, to the other pathway of omega oxidation. And when omega oxidation occurs and it is dominant, then its metabolite basically inhibits an important enzyme in the urea cycle called carbamyl phosphate synthase 1, and this inhibition results actually in the accumulation of ammonia, because the enzyme is the first limiting step, is the rate limiting step in the urea cycle, and its function is to incorporate the ammonia into the urea cycle. And when it is inhibited, there is accumulation of ammonia, and the result is actually hyperammonemia. Now, importantly, hyperammonemia is not a blood test, that it is taken regularly at the routine blood test in the internal medicine department. I wish to remind you, and probably most of you are familiar with that, ammonia is taken in a special tube, should be sent to the laboratory in ice, and hence if the attending physician or the treating physician will not think that there is hyperammonemia, he will look at the patient will look somnolent, the patient will look encephalopathic, but actually he does not understand the reason because he does not check for ammonia. And when we examine the literature about the prevalence of hyperammonemia secondary to valproic acid, it is actually quite a common situation. Up to 45% of the patients who are treated with valproic acid because of different etiologies will, in one point during their life, experience hyperammonemia. However, most of those cases are actually asymptomatic, and hence it is very important to stress that to check for ammonia among patients who take valproic acid but are asymptomatic is not indicated. We should not check it routinely, but only in cases when we think there is hyperammonemia, which has clinical significance, i.e. encephalopathy or somnolence. I should also stress another point that this hyperammonemia can happen in the presence of normal liver function test. Okay, and as we had in that case, and this is another important situation, because if the liver function tests are normal, the treating physician does not think that hyperammonemia can actually happen. The hyperammonemia can occur after acute use, which means after acute intoxication or after a loading dose that we give for patients, or even during chronic use for many years, in which we have consumption day by day of the carnitine, and for that usually we need another trigger, such as any other acquired medical condition that result in carnitine deficiency. And in our case, we're talking about a critical illness, as I said, urinary tract infection versus pneumonia. Both situations actually result in catabolism and deficiency in the carnitine, which eventually will lead the valproic acid to go to the omega oxidation direction and inhibition of the carbamyl phosphate synthase 1. As you can understand, most of those cases are reversible, but naturally, if this is left untreated, it can ultimately induce life-threatening coma, and hence the physician should have high index of suspicion for those cases. And following the consultation of the clinical pharmacologist, the physicians actually test the ammonia for that patient, and not surprisingly, the ammonia level was 400, and the upper limit is a bit above 100. So obviously there was a causality here between the hyperammonemia and the somnolence. And we actually, what we did, we stopped valproic acid and we discontinued phenobarbital as well because of interaction between them. I will elaborate about that shortly. We initiated the levetiracetam Keppra for the epilepsy, and we started treatment with L-carnitine intravenous with the loading dose as appropriate, and followed by maintenance dose. And it is possible as well to add lactulose, but we did not add it. And as you can see, with the ammonia level, already the next day, the ammonia already went down for a level of 170, and within 2 days of L-carnitine treatment and discontinuation of valproic acid, the ammonia level went back to the normal range. And on reevaluation, as any good fairy tale in the Walt Disney chapters, the patient finally awoke, and we could prove that the ammonia was actually the reason for the somnolence. And of course, we should ask ourselves how we can prevent that from happening. And the answer for that question is on three main levels. First of all, when we talk about the prescribers, we should increase the awareness. Hyperammonemia due to valproic acid, it's not a secret. You know, it's a known adverse event, but it is known for people who deal with valproic acid, who deal with medications. Most of the residents in the internal medicine department, and we already checked that, we also checked that among our different wards in the hospital, many of the physicians, the young ones, did not know that valproic acid can induce hyperammonemia, which is clinically significant. Prescribers should know that this can be a dose-dependent adverse event, although, as I said, it can be also idiosyncratic because of the chronic consumption of the carnitine. Physicians should be aware of conditions associated with acquired carnitine deficiency. Those conditions can actually be the trigger for hyperammonemia in patients who consume valproic acid for many years and are stable on it. And of course, we should be aware, as in any other case in clinical pharmacology, for potential drug-drug interactions. Because in that case, for example, phenobarbital, which is a very known enzyme inducer, is actually exacerbate the formation of those toxic metabolites secondary to the valproic acid metabolism. And that's why it was important as well to stop the phenobarbital itself. On the level at the level of the industry, I think that the main thing is that to have a proper warning on the drug leaflet. This is something that it is present, it is known. I don't have any specific thing to add about it. And I think that most importantly is to talk about the hospitals and the academy level, because eventually teaching the young physicians about clinical pharmacology or generally about drugs should begin much earlier than the residency. And this can be done using pharmacology-oriented education at the university level as well. And in addition, we can add to that decision support systems with proper alert, trying to avoid what we call alert fatigue at the hospital itself. All those together will assist the physicians to know that there might be an adverse event that they are not aware of, or something which is quite rare, and will assist them, will make them consult a clinical pharmacologist in situations where they are not sure about what to do or what the cause can be. And I would like to end with a quote of Rudolf Buchheim, which probably you all know, that said that fortunately, a surgeon who uses the wrong side of a scalpel cuts his own fingers and not the patient. But if the same was applied to drugs, then they would have been actually investigated very carefully long time ago. But for some reason, because we do not experience those adverse events, it is very easy for us just to give the patient the pill and not even think that we can harm him accidentally. Thank you.
So thank you so much. It was really a great presentation. And it's always, as you said at the end, I think that it's not in the mind of people in healthcare professional that adverse drug reaction are the fourth to fifth cause of death in the Western world, and certainly all over the world. So I was thinking so many times when during this pandemic that sometimes we should put more emphasis and more efforts to deal with drug safety. But this is where we are. So thank you so much. And do you have questions? You have many congratulations.
Thank you, everybody.